I'm very excited for today to continue with our AIMI Journal Club series. And today we're very excited to have Dr. Jonathan Richens joining us. Jonathan is a senior researcher at Babylon Health who got his PhD from Imperial College in quantum information theory before starting with machine learning research. So it's a really interesting transition. And today he'll be talking to us about applying machine learning and causal inference to clinical problems. And I feel like this fits the theme because just earlier today, causal inference was the theme for the NeurIPS keynote speech. So this is becoming more and more of an interesting topic in medical imaging specifically. So we're very excited to hear about your views, Jonathan. And maybe just to give you a high-level sense of the format for this journal club, for the first half hour or 30 minutes or so, we'll be having the presentation that will be recorded. And then for the second half of the talk, we'll stop the recording and then we'll try to have a discussion with questions from the audience. So with that, thank you for joining and we're delighted to hear from you.
Great. Hey, thanks for having me at your journal club today. So just to introduce myself, well, I've already had a really nice introduction, but I'm John. I'm a researcher at Babylon Health, which is a tech company based in London. And we work on lots of different areas in medicine and medical practice that can be automated or improved with algorithms and machine learning. And today we're going to focus on one area of clinical decision making, which is algorithmic diagnosis. And specifically, we're going to look at this recent paper which came out of our group, looking at the role of causality and causal inference in diagnosis. And although this work focuses like purely on diagnosis, I'll also give a couple of examples in the talk and show that this is a problem that extends to clinical decision making more broadly. And just to start, to briefly summarize what this paper is about in a few words, we basically argue that if you want to build an algorithm to do diagnosis in the kind of proper and principled way, then there are a lot of situations where standard approaches aren't going to work. And you have to go back to the drawing board to some extent and really think about what diagnosis is and how we can build algorithms that take causality into account and perform kind of proper diagnosis. And this paper focuses on this kind of causal aspect of that's missing from current approaches, but obviously there are a lot more aspects that we could discuss as well, and hopefully in the discussion. Okay, so one area that I'm not going to touch on in this talk very much because I know so little about it is the importance of causality in medical imaging. But the best I can do is point to a couple of papers that came out around about the same time as the paper we're discussing. And they have kind of similar conclusions, but when focusing on the case that you're working with image data. So the first one is a perspective article in Nature Communications, which is kind of focusing on how it's important to understand the causal relations between the features and the labels in image data. So for example, it could be that the features of your data that are causing your class prediction are actually these spurious confounding features that have nothing to do with the underlying condition you're trying to detect, but are nevertheless correlated with the disease by confounding variables like the time of day the image was taken. And so when you run your classifier on data generated in another hospital, it often fails to generalize, but really it's because it was picking up on these confounders that vary between hospitals. And it's almost immediately after we published our paper, a paper cited it, this exact problem, but with X-rays in detecting COVID. So this is starting to show up in interesting empirical work. Okay, so that's what we're not going to be covering. What are we actually going to be covering? So we're going to start by taking a small step back and looking at differential diagnosis. And this is going to be quite informal. I'm not going to be diving into any of the theory and philosophy of medical diagnosis, but just giving a kind of cartoonish summary of what's going on when a doctor performs diagnosis on a patient. And then if you're interested, it's easy to find these old medical textbooks and papers from decades ago that basically define diagnosis as a causal inference task in so many words. So you could argue that there's nothing in our paper that's particularly novel, but it's just that computer scientists weren't reading these old papers. It's almost a cliche that I'm sure a lot of you have found in your work, that you think you found something new and cool, and then it turns out some American or Russian guy discovered it 30 years ago. But anyway, so after that, we're going to look at some simple examples of diagnostic algorithms and clinical decision support systems. And we're going to ask why these algorithms have struggled to kind of live up to their promise and do as well as human doctors. And of course, there are lots of reasons why this might be the case, but we'll focus on the lack of causal reasoning in these approaches. And then I'm going to describe precisely what I mean by causal reasoning and how we can, well, one approach to building algorithms that can understand cause and effect. And then we'll see how these new, excuse me, how these new causal algorithms perform compared to the older ones when compared to human doctors. Okay, so what's the problem and why should we care about it? Well, at Babylon, we're looking at primary diagnosis, which takes place as you know, in primary care, when a patient first interacts with a clinician. And it's also differential diagnosis, because we're trying to differentiate between multiple possible conditions that could explain a patient's symptoms, rather than just, say, deciding if an autopsy shows cancer or not. Excuse me. And we also care about primary diagnosis because it turns out that diagnostic errors in primary care are a big deal. They're one of the main burdens on global healthcare systems, according to the World Health Organization. So to give an example, in the US, about 20% of patients with serious conditions are misdiagnosed at the level of primary care, and about 1 in 3 of these misdiagnoses then results in serious patient harm further down the line. So what's going on in primary differential diagnosis? So we have this initial interaction between a patient and the care provider, which yields a description of the patient's medical history and their current symptoms. And we want to map this to some initial diagnosis, which will then inform things like how we triage a patient, how we follow up with examinations and tests. So in this example, the patient has symptoms like fever and abdominal pain, and we want to know some relevant medical history, which we'll call risk factors. And these are anything that could make certain conditions more likely in their prior. So demographics, basic physiology like weight, any previous diagnosed conditions, and so on. And and the output that we desire is just a big list of posterior probabilities over all of the diseases and conditions the patient could have. So what's the probability that a patient has a new presentation of some disease D, given that they have these 3 symptoms and these 2 risk factors, for example? And then we calculate this for every single disease in our model that we're interested in. And then you just return a list of diseases and their posteriors, which is confusingly also called a diagnostic differential. So this is like a very simple kind of toy model of diagnosis. So something worth mentioning here is that to do this, we have to compute a lot of outputs. So the posteriors over a lot of diseases, and our inputs are varying a lot from patient to patient. So there are thousands of symptoms and exponentially more combinations of symptoms that a patient can have. And we usually only get a few bits of evidence for a patient in the kind of golden minute interaction that they have with a care provider or a chatbot or whatever. Also, sometimes we know that a patient has a disease. So that disease could be comorbid with a disease we're interested in. So diseases can also be evidence. So you need a model where you can swap inputs for outputs. So this is one reason why historically, and I'm talking like, going back to the 80s, people have often used Bayesian networks as models for differential diagnosis. It's not the only reason, but it's a key one. So Bayesian networks, I'm sure everyone here's heard of them, but it's just a graphical representation of a joint probability distribution and the conditional independences therein. So for example, here we have a 3-layer Bayesian network with risk factors on the top layer, and then these cause diseases, which are on the 2nd layer, and these in turn cause symptoms on the 3rd layer. And the nodes in this graph represent the variables we're interested in, and the arrows form what's called the directed acyclic graph, or DAG for short. which in this case is simply encoding that a risk factor is a parent of a disease if it causes that disease, and we draw an arrow from the risk factor to the disease. And likewise, if the disease causes a symptom, we draw an arrow between them. And the joint distribution then factorizes with respect to this DAG by the Markov property, which you can see in this equation on the bottom left. So the joint distribution is just a product of marginal distributions for every node in the graph conditional on its parent. And yeah, so as I alluded to before, these Bayesian networks are generative models, and they have some properties that are really nice for differential diagnosis. So the key point I mentioned before is that with generative models, we can fix observations on any of these nodes in the network and calculate the posterior probability for any of the remaining nodes. So we can learn just one big model for all the variables we're interested in, and then swap inputs and outputs on the fly. And there are, like, I'm sure you've all heard this before, but there are lots of other reasons why you might want to choose a Bayesian network. So you can incorporate expert knowledge. A good example of this is the DAG itself that I was just talking about, which is a kind of expert causal knowledge of which diseases cause which symptoms and so on. And this turns out to be really important later, and something that's very hard to do with discriminative models. And they can also give you, interpretable decisions. You can extend Bayesian networks to influence diagrams, which I won't bore you with, but this lets you automatically generate explanations as to why you reached a given diagnosis, which is obviously very important. But yeah, I would also be lying if I said that there weren't some major drawbacks. Bayesian networks are super hard to build. I think at Babylon, we've got one of the biggest in the world, and it took years and like an army of doctors to build. Tractable inference is often impossible, and they just aren't often as accurate as discriminative models like function approximators. Choose one. So before we plow ahead with Bayesian networks and that approach to diagnosis, I just want to take a few minutes to look at some other approaches to diagnosis and clinical decision making, because I think these also give a hint as to why we need causal information that we find in Bayesian networks. So we're going to look at two examples where data-driven machine learning methods were used to perform diagnosis and clinical decision making. And by data-driven, what I really mean is that these methods were trained on observational data sets like electronic health records, and they don't have this expert causal knowledge encoded in them like the DAG we saw before. So the first one, which is a very nice paper, Nature Medicine paper from last year, is where the authors use this kind of deep learning architecture to extract clinically relevant features from over about 1 million electronic health records, culminating in about 100 million data points. And they use this to build a hierarchical model for diagnosing pediatric conditions. And the results are really promising, but on average, they didn't outperform human doctors. I should say that the main innovation of this paper was more in how they extracted information and useful medical concepts from EHRs. But the fact that their algorithm learned on over 100 million data points, but still was struggling to beat human experts, is interesting, because probably none of those doctors would have seen so much data in their lifetime in training. So perhaps this hints that we're missing something. Perhaps diagnosis isn't something we can throw data at in order to solve. The next example, which is even more telling, is not a diagnostic algorithm, but the principle is very similar. It's a study from 2015, where the authors developed a system for predicting the mortality risk in patients with pneumonia. And the really interesting thing about this study is that they trained a suite of all these different machine learning models to predict mortality, including neural networks and rules-based models. And what they found was that the models learned that patients with asthma who were admitted for treatment for pneumonia had a lower risk of mortality. So the algorithms then learned to recommend that asthmatics receive less aggressive treatments than non-asthmatics, even though it's well known that asthma is a serious risk factor for mortality in patients with pneumonia. So what's going on here? Well, it turns out that the algorithms were actually right, but they were asking the wrong question. So if you observe the data, you see that asthmatics do have a lower mortality risk, but it's not because asthma is a protective risk factor for pneumonia. It doesn't mean we should treat asthmatics less aggressively. It happens because the doctors in the hospital knew that asthmatics were at a higher risk of mortality, so they gave them more aggressive treatments, and this led to an overcompensation that reduced the overall risk. So this can be visualized with this simple causal model here, which is like the Bayesian Networks I was just showing. So you have asthma, which is the node A, which has a positive causal effect on mortality M. So it makes a pneumonia patient more likely to die, but it also has a positive causal effect on the level of care, T, that they receive. And this has an effect of reducing the overall mortality risk. So there are two causal pathways from having asthma to mortality, and they interfere in this complex way. And so overall, the asthma has a negative correlation with mortality, despite having a positive direct causal effect on mortality. Now, the algorithm is just looking at the data. It doesn't have any understanding of the role of cause and effect in how the data was generated. So it learned this spurious belief that asthmatics are a lower risk, so they should not receive aggressive treatments. So clearly something's very wrong here, and it turns out that the problems encountered in this paper, in these two papers, are related. The algorithms are learning directly from data, but they're arriving occasionally at the wrong conclusions. So what are we missing? And to answer this, we have to go back to basics and try and reconsider our assumptions about what diagnosis really is. So returning to the previous definition, diagnosis is all about taking some evidence E and some model theta and using these to estimate the probability of different diseases. And here I'm using Bayes' rule, but you can just fit a function if you want. And this is what's been believed in the kind of computer science community for decades, but it's not the full picture. So consider the following example. We get an elderly patient who smokes and reports chest pain, nausea, and fatigue. And a good doctor will choose a primary diagnosis that's a good explanation, not only likely, but a good explanation of these symptoms. So for example, they could say angina. So angina causes all three of these symptoms, but it's also true that given the evidence the patient provided us, we know the patient belongs to a subpopulation of old smokers who have a high prevalence of emphysema. Now, if the doctor was to only select diseases based on their probability, their posterior probability, given the evidence, they could end up selecting emphysema in spite of the fact that it doesn't cause any of the symptoms presented by the patient. So this pretty simple argument shows that we can see that, the kind of classic probability-based approach, which we'll refer to as associative diagnosis, is insufficient. No doctor in the wild is doing this kind of reasoning. And what we propose in our paper is a slightly different definition, that diagnosis is the task of identifying the diseases that are the most likely underlying cause of the symptoms of a patient given their medical history. And this difference seems quite subtle, but it gives really different results. And it's also kind of worth noting that, to our knowledge, we haven't seen this approach tried in the diagnostic algorithm before, in medicine or outside. So next we have to figure out, how do you build an algorithm which obeys this slightly hand-wavy definition? So to do this, we need a mathematical calculus for making inferences about cause and effect. And the simplest way to understand this calculus is with Pearl's ladder of causation, which you can think of as kind of a simple taxonomy of the different kinds of inferences we can ask causal models of the type I've shown on the previous slides. So normally we take a probabilistic model and we ask things like, what is the probability true given that B is true? But it turns out that this kind of question is only the simplest inference you can make. And if we want to ask more complicated questions about actions and causation, like what would happen if I changed the value of A, or did A cause B, then we need to apply a whole different set of rules and inferences that go beyond Bayes' rule. And there are three rungs to this ladder. The first deals with passive observation or seeing. The second asks questions about actions that we could take, where we intervene on the world and change things. And at the top of the ladder, the most complicated kinds of inferences we can make are counterfactuals. And these can be thought of as kind of imagining alternate realities or seeing how things would be different. So to illustrate these different rungs on the ladder with a simple example, you can consider the following model. We have a population of people, some of which have a hidden genetic factor lambda, which makes you predisposed to smoke and more likely to develop lung cancer too. So smoking could also cause lung cancer, shown by the arrow between S and C. But we want to determine how likely it is that a patient's lung cancer was caused by genetics and how likely it's caused by smoking. So if we only look at correlations, so the probability of cancer given smoking, we can't say anything about causation. So in this example, it could be that smokers get cancer because smoking is a very strong cause of cancer and the genetic factor has a very weak effect. Or it could be that the correlation is almost entirely due to lambda, and smoking rarely causes cancer. So you can be either of these scenarios, but you get the exact same value for P of C given S. So these are the kind of questions that these previous models were asking, these kind of passive observation models. So to figure out causal effects, you have to do experiments, obviously. So this moves to the second rung of the ladder, which deals with interventions. And in this example, say I wanted to determine if smoking causes cancer, I could do a randomized control trial where I flip a coin, and if I get heads, I force someone to smoke. If I get tails, I force them not to. And this breaks the influence of the genetic factor lambda on the smoking variable, which we can see here by removing the arrow from lambda to S and fixing the value of S, forcing the person to smoke. And if the cancer rates were higher in the population that I forced to smoke, I conclude smoking causes cancer. Nothing surprising. Now, obviously, this isn't an RCT that I could actually perform due to ethical reasons. But this operation, which I described, cutting the arrow from lambda to S and then fixing the value of S, is a mathematically well-defined operation summarized by the do operator. We can use this causal calculus developed by Judea Pearl and others to estimate the outcome of this do operation without actually having to perform it in the wild. So this little equation, if anyone's interested, this little equation on the bottom left tells you how to calculate the probability of getting cancer given I force you to smoke, assuming this model that I've shown here. And it's literally marginalization on this mutilated model. So I've cut the influence from lambda to S, so I calculate slightly different marginals, and then I marginalize over them. So very simple in this case. And that's all well and good, but we want to ask a slightly different question, which is, if someone developed cancer, what is the probability that this was caused by smoking rather than something else like a genetic factor? And it turns out you can't answer this question using an RCT. So even if you know that smoking causes cancer, it could be that for 70% of the population, smoking always causes cancer, and for 30%, it actually protects, so it stops you getting cancer. Or it could be that smoking causes cancer in 50% of the population deterministically, and the rest get cancer or not, regardless of whether they smoke. And in these two different models, you get exactly the same results in your RCT, but they provide different answers to this question that we want to ask. So what we want to know is, given that someone got cancer, would they likely have not gotten cancer if they had never smoked? And this is captured by this odd-looking probability on the bottom right here, which says that given this person got cancer, if I could go back in time and stop them from smoking, would they have still developed cancer? And if this probability is very low, then someone would have not have gotten cancer. Would have gotten cancer whether they'd smoked or not. Whereas if it's very high, then it's almost certain the person's cancer was caused by the fact they smoked. So this very strange-looking probability is a counterfactual. It's actually a many worlds counterfactual. So if anyone in the room is familiar with the potential outcomes framework, this is separate from that framework or generally not calculated there. And I say it's strange because it has two contradictory statements in it. Cancer is false and cancer is true. And this is where it gets its name from. The statement cancer is true is the factual evidence the patient does have cancer. And the statement cancer is false is the counterfactual, as in it's counter to the facts. Okay, so these counterfactuals are what we want, we think. They tell us how likely it is that some outcome that we observed was caused by some past event, like if a symptom was caused by a disease. But then how do we use them for diagnosis? So let's go back to the previous example of a diagnostic Bayesian network. And what we normally do is take the evidence the patient gives us, which is their risk factors and their symptoms, and then we apply Bayes' rule and calculate the probability of every disease in our model. And this is going to be our baseline algorithm, and it's stuck on the first rung of this ladder that I was just describing. But then we're going to compare this against a new query, which we call in the paper the expected disablement. And this query is based on these nice counterfactual probabilities, and it's very similar to the one we just saw in the previous example with smoking. So the expected disablement measures the number of symptoms that a patient has that we would expect to be switched off if they had never had this disease in question. So the larger the expected disablement is, the more symptoms we think the disease is causing. So yeah, just to briefly explain this equation, we can look at the simplest example. There's only one disease and one symptom. The patient comes to us with this symptom, and we calculate the expected disablement by summing over every possible counterfactual symptom state that could exist. So there's one symptom, so there's two states that could exist. And to calculate the expected disablement, we expand out this equation, and we can see here it just reduces exactly to the counterfactual probability that we saw in the smoking and cancer example. So the probability that the symptom would go away if we went back in time and prevented them from having this disease. There's a slightly more complicated one here, but I've realized it's on 25 minutes already, so I might skip it. I think you get the idea. Okay, so we've now defined our query. How do we actually calculate it? So it's quite complicated in practice. To do this efficiently, you use these things called twin networks. But the intuition behind them is quite simple. So consider this simple case where we have two diseases and a single symptom and a single risk factor. And say the patient comes along and says they have this symptom, and it could be caused by disease 1, or it could be caused by something outside of our model. So the patient could have just randomly gotten a headache. It has nothing to do with diseases. And then there's also this other disease 2, that doesn't cause a symptom, but it's connected via this risk factor, like smoking. So this is like in the angina emphysema example that we saw before. So to calculate the counterfactual, we start by setting the factual evidence that the patient presented on the symptom, and we use Bayes' rule to update the probability over all other variables in our model. So this step is called abduction, and it basically tells our model to update to give the most probable distribution of all of the unseen variables that we think would have generated the patient that we saw. So for this patient, it's not very likely they have disease 1, but it's fairly likely that they are a smoker, and if they have this symptom, and so this risk factor gets updated, and then because this risk factor gets updated, so does disease 2. So they belong to a population where this disease 2 has a high prevalence. And if we were doing good old-fashioned diagnosis, we'd stop there and just read off the probabilities of the diseases. But for the counterfactual, in the next step, we perform this do operation that I was describing before. So we intervene on disease 1 and switch it off. This is like adjusting the preconditions that gave rise to the symptom in the first place. So it's this thing where you imagine going back in time and changing what happened. So this remember the do operation says cut all the arrows going into disease 1 and then set the value of disease 1 to 0. So it's that you don't have it. So this intervention doesn't update any of the variables upstream of the disease. The risk factor and the second disease posterior stay the same because of that cut. But the symptom downstream of the intervention has its probability changed. It's gone from being on with probability 1 to having quite a low probability of being on. now we've switched off this disease. And then when we read off this probability, this is exactly the counterfactual that we wanted. So all we've done here is apply kind of standard inference techniques and this do operator in a specific order to a causal model, and there's nothing more to it. And yeah, again, we see the counterfactual probability is small, so we can conclude the symptom probably wouldn't be on if the person didn't have this disease. So it's very likely this was the cause. And then if we imagine we do exactly the same thing for disease 2, so disease 2 had a high probability, but the counterfactual turned out to be 0 because the symptom in question isn't downstream of disease 2. So the intervention won't change the factual evidence. So this makes sense if I was to change something that wouldn't affect the data I saw, but everything else in the universe stayed the same, I would expect to see exactly the same data. Okay, so that's the theory out of the way. The next thing we need to do is to test this in the real world and see if it does any better than the old-fashioned posterior inference approach. So to do this, we use a panel of doctors to generate a test set of simulated diagnostic cases. These are like realistic examples of a condition and the kinds of risk factors and symptoms along with that condition that you might see in the wild. So in this example, we have a peptic ulcer. We know the age and gender of the patient, some typical symptoms we might see with this disease. And these simulated cases are often used for assessing doctors in the real world. and they're nice to work with because unlike with EHRs, you don't have to worry about mislabeling features or not having access to ground truth labels for the diagnosis. So we took a couple of thousand of these and performed 2 experiments where we gave the vignettes to 44 separate doctors and we also fed them into our algorithms. And again, the baseline algorithm is just the standard posterior inference on a Bayesian network, and the new algorithm was the expected disablement. And they use exactly the same Bayesian network. So we know that any difference in their performance is purely down to the kind of question we're asking them. It's not down to changes in the model. So in the first experiment, we just compare the 2 algorithms. We forget about the doctors. The graph on the right shows the top K accuracy, which is the percent of cases where the ground truth disease shows up in the top K diseases as ranked by the algorithm, either using the posterior or the expected disablement. And the blue curve is the error of the correlation-based algorithm, and the green curve for the counterfactual algorithm. And you can see there's a pretty clear gap between them. So the black dotted line shows this a bit clearer. This is the relative reduction in error rate. So if this was at 0.5, then the counterfactual algorithm is getting the wrong diagnosis about half as frequently as the standard one. And we can see that, in a reasonable differential size of 4 or 5 diseases, we're doing about 30% better, which is non-trivial. And interestingly, we found that the diseases that we were preventing diagnostic errors on were precisely these kind of rare and dangerous diseases, and less the common ones. So for the serious diseases that are causing this big burden in healthcare systems, it's more like a 50% reduction in error rate. So that's fine, but what we really want to know is like how do these things compare to real doctors? So we took these 44 doctors, we gave each of them a random subset of our cases, and each doctor was permitted to return however many diseases they would want to if they were just performing their normal practice. So if they're very confident, 1 disease; if they're very uncertain in the case, maybe 6 or 7. And then we gave our 2 algorithms exactly the same vignette that the doctor just received, but then we asked them to return exactly the same number of diseases that the doctor did. And they get all parties get a score of 1 if the model disease is in their differential, or a score of 0 otherwise. So this is just to allow for a fair comparison. Now, when we do this, the results are still quite striking. So we find that on average, the doctors guess correctly 71% of the time. These are quite challenging cases. The correlation algorithm got it right 72% of the time, and the counterfactual algorithm 77%. So this is a relatively significant difference on a doctor-by-doctor basis. The correlation algorithm beat about as many doctors as it lost to. So it's doing about as well as the average doctor, like we saw in the Nature Machine Intelligence paper, Nature Medicine paper. So. But the counterfactual algorithm is coming in the top 25%. And you can see this quite clearly on these two plots. The x-axis is the accuracy of each of the 44 doctors, and the y-axis is the accuracy of whichever of the two algorithms is shading that doctor. And this diagonal line is just the y equals x line. So if a point lies above it, the algorithm's winning. If the point lies below it, the doctor's winning. And you can see there's this shift when we go from the left, the associative algorithm, to the right, to the counterfactual algorithm. Okay, so in summary, we've seen that kind of classic diagnostic algorithms and more broadly kind of classic clinical decision support systems, which are based on correlations between patient evidence and diseases, have some pretty strong limitations in some cases. And we've presented, well, we've kind of tried to present the first kind of diagnostic algorithm that uses causal and counterfactual reasoning to diagnose in a way which is perhaps closer to the reasoning of a human doctor. And we see that this does give a big jump. But importantly, these improvements come for free. We didn't have to learn any new models. We just had to ask our models a different kind of question. So I think if there's anything that I sort of learned from this study, I'm pretty new to the field, but it's that kind of having a more complicated model or model architecture or more data is definitely a wonderful thing, but it's not the only path to improving our models. We can try and implicitly bake causal and counterfactual reasoning into them, which we know are kind of like primitives of how humans do reasoning and perform tasks. So yeah, that's the talk. Thanks very much.